I would request Dr. Mohan Rajan to get ready with his presentation on an ideal IOL formula. Can be brought up on the screen?
Okay, thank you, Arup and KSOS for this wonderful opportunity. It's always a pleasure. I think it's more than 2 decades I've been coming for the Kerala state. Kerala is like my second home. I always cherish my association with the Kerala's KSOS. The ideal IOL formula, actually, it's a misnomer because there's no ideal IOL formula because it's a very huge topic. It's very difficult to cover, and these are my financial interests. As you know, the sun is setting on the old mindset of cataract surgery. What is the old mindset? Is typically an older patient. Now we have younger, active in life, economically independent, educated, hugely aware of the options. And the keys to the refractive cataract surgery is increasing refractive accuracy, good biometry, address astigmatism, decrease complications, avoid corneal edema, PCR, choose the best quality visual IOLs, and always exceed the patient expectations under promise. The goal is happy patients. Results exceed the expectations. As you know, hematropia is the goal, as Arup was rightly telling. What's the point in doing a good surgery and putting the wrong IOL power? The recent trends is that early cataract surgery expectations are high. Refractive power of the human eye depends on 3 factors: the power of the cornea, the power of the lens, the length of the eye. You know the problems with the manual keratometer. Sandhya beautifully mentioned that. Advantages of the IOL 700. I think if you have the money to put, all of us are cataract surgeons, many of us are cataract surgeons are here. I think put the money on the microscope and put the money on IOL Master 700. It's worth instead of putting the money in your car or something like that. So the applanation or immersion and non-contact, I would say that I think we should, in the today's era, let's say no to applanation, but if you have access to optical biometry, probably that is the best, but you can do immersion, get away with good results as well. I just compared the A-scan with the Maruti 800, which is good at that point of time, but no more. And that is the applanation contact A-scan with the IOL Master Lens Star with the Audi and the IOL Master 700, which is the Ferrari. Optical biometry, as you know, that all the parameters are there, which I think Sandhya beautifully mentioned. But what is more important is the Swift-Society gives a 3D image of the eye, an accurate data of the ACD, lens thickness, vitreous. The total keratometry, that is the total corneal power, is very, very important. Again, the type of the cataract is also important. Ability to penetrate even posterior polar cataracts and mature cataracts, another important thing. Ability to get the macular image. So everything is there. If you have, I think it's worth putting the money because we are all, the cataract is bread and butter and you want to get the best for these patients. So IOL power calculation, you need to consistently hit the bulls like it is like Sachin Tendulkar hitting a century every innings. It's possible. Okay, axial length, corneal power, the effective lens position or the A constant, and it's very, very important. The gold standard, everybody knows, keratometer, A-scan, the SRK formulas, the SRK, which are called the regression formulas, the SRK-T, which is pretty good, but still, in the normal eyes, it's probably good, but in the extreme eyes, it's probably not very good. So let's understand what is this effective lens position, IOL power. The distance between the IOL and the cornea, the A constant in SRK-T, from the iris plane, there is a surgeon factor in Holiday 1, whereas the Barrett Universal tool takes the lens factor. But the most important thing is the ELP decreases in shorter eyes, that is in hyperopic, and flat corneas, increases in longer eyes and steeper corneas. If you look at this diagram, it's beautifully mentioned here, that the ELP is from the cornea to the lens. But what happens is when you have a const, that is the, for example, the ACIOL, I think Ellen Kumar was mentioning about that, the A constant becomes less, the effective lens position becomes less. That is 1/5 or something like that. But if you have a lens in the sulcus, it will be 1/7, and if a lens in the back, it will be 1/8.5. Again, the various formulas like the theoretical, the regression, the divergence formulas, the ray tracing, which is coming into a big way, which is going to be the future, which is not only ray tracing, but also using artificial intelligence as well. The multivariable formula, what is happening is they found that the eye is not a single this thing. There are multiple variations in each eye, and multiple variations are accounted. That is the reason why these new generation formulas are performing much better. The 2-variable formula, the 3-variable formula, the Hedges, and the Barrett, which is a 5-variable formula, where is the axial length, the corneal curvature, the anterior chamber depth, the lens thickness, the corneal diameter as well, and of course the Holiday 2, which is called the 7-variable formula. Incorporating both the theoretical, there is geometrical optics and regression formula, better prediction of ELP, and that is what I think we are going all towards that direction. If we are able to predict where the lens is going to sit, okay, then we probably hit the bullseye consistently. And biometric variables. This is the Royal College recommendations way back in 2018. Less than 22 H's or offer Q. If it's between 22 and 26, you can go for SRKT, which you are all normally using. More than 26, then we can go for SRKT or H's formula. The formula makes a difference because in the older formulas, you can get up to 70 to 75% or 80% patients within plus or minus 0.5 range, which is pretty good. But the problem is we now have patients, about 25% of the patients are outside this, what I call the outliers. So we need to get a formula which you can get, you can't get 100%, but at least 90 to 95%. Is it possible? It is possible with the Barrett formula and the newer generation formulas. If you take the Holiday, this is everything, the normal configuration of eyes, which is about 73.4%, and this probably SRKT will work, and you'll be able to get these this thing. This is the IOL formula, which we used to do that before. Average, you take the average of 3 formulas when you have a 22 to 24.5 millimeter of axial length. If it's shorter eyes or longer eyes, then go for a newer generation formulas. These are the various formulas. But Barrett Universal 2, what is the advantage? This is the formula which I am going to for all my patients. Simply because this is a formula which is not only versatile, it is accurate, user-friendly, and variables are incorporated. It's a multivariable formula. Availability is there. It is available freely on the APACRS, ASCRS website. And that is the reason why the Barrett Universal 2, and it's truly universal. So it can go for normal eyes, short eyes, long eyes, post-LASIK, keratoconus, post-silicon oil. And if you have an IOL Master 700 and the Barrett formula, it's nothing like that. You can consistently hit the bullseye. You have the Barrett suit. That is the Barrett's universal formula, the toric formula, the Barrett's formula for secondary IOLs. Ilan was talking about it. The True-K formula, which is again for the post-LASIK, the refractive surgery patients. Newer formula, you can see here, the newer formula is there. For example, the Kane formula, it's coming up in a very big way. Again, using part of the artificial intelligence, Hill RBF formula is also there. The challenges are also there because if you have patient keratoconus, what I do is I just go in for the Barrett or the Kane formula, which is available with this thing. But the problem is many people don't have this IOL Master 700. I would strongly, advocate all of you to go in for a IOL Master 700. If not, Emotion A-scan is good enough, and go for the Barrett formula, universal formula. Refractive suppressors, axial length, corneal curvature, after corneal refractive surgery, radial keratotomy, excimer laser surgery, everybody knows. Presence of pterygia, I think this is this thing which is very, very important. False readings may be due to induced astigmatism of the pterygia. Do a pterygium excision first, and then do the cataract surgery after about 3 or 4 weeks when the cornea stabilizes. Strabismus, always close one eye and do the biometric measurement. Post-silicon oil, Arvind beautifully mentioned that. High myopia also is very, very important. Why our formula should not be optimized with Caucasian database? Because the Indian cornea is thinner, and the lenses are also thinner when compared to the Caucasians. So that is the reason why I think it's very, very important. We have the optimized optical biometry A constants, Hage's website, at India-specific A constants for each formula. Again, very important, the Barrett suit is probably the ideal formula for optical biometry users. For the immersion, if the careful optical biometry and the current formula, especially the Barrett's Universal 2 and the Barrett suit, we can get up till 92% of the eyes within 0.5 diopter, which is phenomenal. And the take-home message is accurate keratometry values, consistent axial lengths, appropriate formulas, optical biometry. The formula for 2022, as I'm standing today, is Barrett's, Kane, or the Emetropia EVO formula. And careful measurements after optimizing the corneal surface, very important. Okay, don't touch the cornea and don't do the keratometry. Even the NCT can alter the corneal surface. Make sure the dry eye is taken care before you do the corneal measurements. Royal College advice for ultrasound biometry. Kane, EVO, and EVO, Barrett's, Hill RBF formula for with optical biometry is the way to go. What are the recent advances and future trends? Intraoperative wavefront abrometry, the ORA, which is OptiWave refractive analysis, which can actually find out intraoperatively what is the power of the eye, the total corneal power, the cylindrical the axis as well. Greater accuracy in measuring the total corneal power. That is, I think, where we are getting into. ELP protection also is very, very important because that is the game changer in my opinion. Smaller dioptric increments of about 0.25 diopters. So accuracy of the IOL biometry, single calibrated biometer, repeating and verifying measurements by a second instruments, appropriate IOL formula, optical biometry or emotion biometry if you have no access to optical biometry, newer IOL formulas and personalizing lens constant for each formula, perfect capsular axis. I don't have to emphasize the importance of perfect capsular axis. Yes, and it's again very important because if you have a smaller axis, you can go for phimosis. They can push the lens back and can have an hyperopic shift. If you have a larger axis, the lens can move forward. There can be a myopic shift as well. We are at the cusp of understanding how better quality measurements and large population of specific database will improve power calculations in different ethnic groups of the world. I should acknowledge the contributions by Dr. Arup Chakrabarti, Dr. Ramesh Durraj, my colleague in Chennai, and Dr. Atik Sheikh. And if people have access to the demystifying IOL power calculation by Arup, it's probably an eye-opener for all of us in the Delhi Journal of Ophthalmology. Thank you again, Arup, for the wonderful opportunity and the patient attention of all the delegates.
Thank you very much. We have just finished on time.